Next, I have Dr. Lightfoot. Nate, are you ready?
Yes.
Perfect. Thank you, sir. So, Dr. Lightfoot is going to cover with you a little bit off Doppler topic, which is the actual use of B mode ultrasound. This is not directly Doppler, but has significant relevance with regards to ICP evaluations. And he's going to cover B mode ultrasound for cerebral edema assessment. Thank you, Nate, for joining us.
Sure. Can you confirm that the slides are progressing for me?
Mhm. And we can hear you well.
Okay, great. Thank you for the introduction. Like I said before, I'm Nathan Lightfoot. I'm a vascular neurologist here in Kansas City, Missouri. I'll be talking to you today. It's a little bit of a different talk than the others. It's about B mode ultrasound of the brain and its utility for cerebral edema assessment. And so the reason this talk is a bit different is, B mode ultrasound is, the research surrounding it and its use in the hospital is sparse, and it's even a more hyper-focused talk when you're using B mode ultrasound to assess cerebral edema. And so you'll kind of see that as I give this talk, that it goes from quite simple to very hyper-focused. And the data supporting its use in cerebral edema is really reliant on just case series that have been done. There's very little standard guidelines or protocol on how to do it. But I only have 10 minutes, so let's get started. I have no disclosures, no conflicts of interest. So as I said, intracranial ultrasound using B mode is not a common application of ultrasound. As we've been talking today, the most standardized use of ultrasound is TCD, really used for detection of vasospasm and subarachnoid hemorrhage. But beyond that, not much usage for B mode ultrasound. Um, However, I guess this is really due to the skull limiting insonation, and so B mode ultrasound hasn't gotten a lot of traction. But if using the same, spots of insonation that we use for TCD through that squamous portion of the temporal bone, with the right settings on the ultrasound, these limitations can actually be overcome, and you can get really great pictures like the one here on the left. Hopefully you can see my mouse. Um, and so with that picture, and also with the corresponding head CT next to it, I'm trying to kind of provide a basis for everyone using this B mode ultrasound. And throughout this presentation, when I show an ultrasound image, I've tried to include the corresponding head CT just to give you kind of a foundation there. So very basic here in figure A, you can see the thin portion of the temporal bone called the squamous portion. To get B mode ultrasound images, this is the area through which you insonate, but the real trick here is to use a low frequency probe, a low frequency phased array probe at 1 to 3 megahertz, either at the transcranial, if your machine has it, or the abdominal preset. Figure B is Dr. Ari Sarwal, you can see there, but it shows the correct orientation of the probe to access this window. And so to obtain that axial view, like I had just shown in the last slide, you want the index marker pointed anteriorly at the level of, and you want the level of insonation to be approximately at the level of the basal cisterns. So after proper placement of the probe in the axial plane, you should get an image similar to this. In this plane, you can already identify some important structures. What you're seeing here with the blue arrows is outlining the opposite skull. That's down here. And the skull curvature, along with other landmarks, can help orient you to what plane you are in. Moving inward, you can see this hypoechoic structure that I'm outlining with my mouse. That's the midbrain. I would nickname that spot the black butterfly. So it's kind of used as your first landmark when you're putting the probe on the patient's head. On that midbrain, you can see that what would be the wings of the butterfly corresponds with the cerebral peduncles. And probably a couple other notable points here is that really hyperechoic dot here in the middle of the midbrain is the cerebral aqueduct, and this hyperechoic surrounding area is the CSF in the basal cisterns. Um, so after you are at that level of the basal cisterns, you can either rotate the probe superiorly or rotate the probe upwards, or just slide it superiorly, and then you can get a view of the more of the supratentorial structures. Again, with the blue arrows here, I'm actually pointing to the choroid plexus, which is lining the lateral ventricles. This can be more easily seen on the ultrasound when there's actual calcifications of the choroid plexus. And when that is happening, you can see the occipital horns of the lateral ventricle here, and then some part of the frontal horns of the lateral ventricle. This image is the same one, but what we're really pointing to here is using the ultrasound, you can pick up on meningeal projections in the brain. Um, this one in particular is pointing to the posterior portion of the falx running between the two hemispheres. If you rotate the probe and try to obtain an image in the coronal plane, that can also be done. In this image, I'm showing you the falx running between the occipital lobes, as well as the tentorium here, dividing the cerebellum and the occipital lobes. And this orange arrow is pointing to the hypoechoic midbrain that we saw initially as the butterfly in the axial plane. Kind of a unique application of the B-mode ultrasound here. This is actually an image of a 5-year-old from pediatric neurologist John Wright, who were working together to create an atlas for intracranial B-mode ultrasound to kind of serve as a template and to help educate others to use B-mode ultrasound. So kind of creating that foundation for reading B-mode ultrasound, now we can kind of dive into how it can be used for cerebral edema. So unfortunately, direct visualization of edema with B-mode ultrasound is almost impossible. The sound wave reflections from the fluid shifts isn't happening to a large enough degree to create a clear image of edema. And I'm going to show you that here. This top image is a patient with a posterior basal ganglia hemorrhage. The abnormality is actually easily seen on the ultrasound, but what is not seen here is kind of where the blood ends and where the surrounding edema begins. You can easily see that on the head CT, but it's indistinguishable on the ultrasound. The bottom image here is again in the basal ganglia, but this is a tumor with an actual very clear surrounding border of edema, quite thick here. But on the B-mode ultrasound, you can't see tumor or any of the corresponding edema. So kind of just further driving home the point that direct visualization of edema is not possible, but if you rely on other indirect signs, as we commonly do with images for measuring and assessing edema, you can do that on the ultrasound. So the first person to really utilize B-mode ultrasound to do this was Seidel and colleagues in 1996. Um, they were the first to assess this, and they assessed 18 stroke patients within 12 hours of stroke onset, and then followed them for 3 weeks compared to healthy controls, and reached the conclusion that transcranial ultrasound is a reliable tool for monitoring cerebral edema. And they did this by assessing displacement of the third ventricle, which seemed to be the most sensitive space on the ultrasound where they could measure shift. After following Seidel's work on displacement of the third ventricle, similar follow-up studies were done performing evaluation of other landmarks such as falx, the septum pellucidum, the middle of the third ventricle, or the pineal gland. Many of these landmarks and how they are assessed are detailed in this stroke article that I've included here from the early 2000s. Sonographic monitoring of midline shift in space-occupying stroke. These measurements that were obtained on the ultrasound were compared to their correlating head CT and were found to be very accurate. And so I'll kind of dive into that accuracy here in these next two studies, which were more recent studies, but they were done on two large case reviews. So here's the first one. Um, this was a study published in 2000 from the European Journal of Neurology, which set out to assess how accurate ultrasound was compared to CT for measuring mass effect, utilizing patients who had a space-occupying stroke or hemorrhage. And what we're looking at here is the results of that study. So the left figure is a linear regression plot. On the x-axis is the third ventricle width in millimeters as measured by the head CT, and on the y-axis is the third ventricle width as measured on the ultrasound. And you can see, with this slope that there's a high correlation here, and statistically they calculated that there was an R value of 0.97, which suggests a very high correlation. The figure on the right is a different way of assessing edema. Basically, they assessed midline shift using the middle of the third ventricle. And again, they found a high correlation with an R value of 0.94. So in conclusion, not only is the R value positive, which suggests a positive correlation, but is nearly one, or close to one, which is the best R value you can have. This is the second study. It was published in the Journal of Critical Care in 2014. They evaluated 52 patients in the neurosurgical ICU with space-occupying pathology, and again found a positive correlation, this time with an R squared value of 0.65. So now I kind of wanted to show you what some of these images look like, if you want to attempt at the bedside to obtain them and try to check for, cerebral edema in your patients that you're taking care of. So here we're looking at the axial view. I'll show you the head CT first. Clearly there's an enlarged third ventricle here between the thalami. But if you take your eyes over here to the ultrasound image, you can see that what the double-headed yellow arrow is pointing to, I guess, or just to the right of it, is these two hyperechoic lines, which correspond with the medial thalami. And you can measure the distance between those two. It's been found if it's roughly greater than 5 millimeters, you're likely dealing with hydrocephalus, which could suggest increased intracranial pressure in the right clinical context. In these two images, we are using the Falks, that's this hyperechoic midline structure here, to measure the degree of midline shift. The image on the left is the measurement from the transducer to the midline. The image on the right is the measurement from the Falks to the opposite skull. And by subtracting these two values, and then dividing by two, you can get an accurate measurement of the degree of midline shift, which can be used to identify midline shift or trend your patient's potentially developing edema. This image, another way of measuring midline shift. Here they're using the center of the third ventricle, and they're measuring from the transducer to midline, and then actually moving the probe to the opposite side of the skull and measuring again from the transducer to midline using that same formula to check for midline shift. So this is actually my last slide here and last image, and it's an unproven way of assessing cerebral edema, but it's actually quite a unique shot of a 54-year-old patient who had a diagnosis of subarachnoid hemorrhage, who unfortunately had her ventricular shunt obstructed. But by placing the probe actually through the occipital or the base of the occiput window, you can see the corresponding enlarged ventricular spaces. And so clearly this is an enlarged fourth ventricle, and you can see the corresponding enlarged fourth ventricle here on the ultrasound, an enlarged third ventricle there, as well as dilated frontal horns of the lateral ventricle. And so that's the end. I'm sorry that was such a speed run through cerebral edema assessment via ultrasound, but I really hope that, if you're not utilizing B mode ultrasound, that you'll consider it. And if you are using it at the bedside routinely, that this served as a good review or potentially as a resource in the future. So thanks everyone for taking the time to listen.